This program is brought to you by Emory University.
Good morning, everybody. Welcome to Friday Morning Fellow Conference. Our speaker this morning is Dr. Pradhum Ram. Dr. Ram is a second-year clinical fellow or second-year fellow in our clinical track. He's originally from India and did his med school in India, came and did his residency in Philadelphia at Albert Einstein Medical Center, where he was a chief resident there as well. And today it looks like he's going to talk to us about pericarditis. So Dr. Ram.
Thank you, Dr. Williams. So basically, hope everybody can hear me okay at this level, but my topic for today is going to be a tale of the inflamed pericardium, basically management of acute and recurrent pericarditis. This topic is of interest to me because while it's not the most glamorous of topics, it's heavily clinical, and often you rely on your clinical senses to aid with this diagnosis. And at the same time, it also is a very morbid condition for patients. So I learned a lot about it recently. Basically, moving to no real disclosures. The only thing is, as always, in pretty much any talk, I'm going to say at some point, larger studies are needed to confirm preliminary results of some studies. What are my learning objectives? Basically, what I'm going to be talking about is essentially what are the established therapies for pericarditis, how imaging can help establish the diagnosis, and in the setting of pericarditis, which is recurrent, what are the therapies out there and what are the therapies that are being discovered now or being put into use that can help manage this condition. So essentially, like most good stories or interesting cases, it started for me on the HERS service last year. That's when I thought of this topic. The asterisk on the statement is because this particular patient had a bunch of admissions or readmissions, and I saw him doing one part of it, so part of the spectrum, but I've kind of adjusted that to kind of portray the whole sort of his clinical course, so that way I can convey the teaching points appropriately. So essentially, he's a 37-year-old guy. He came in initially, with basically chest pain. He said it started maybe a day or so ago. He has otherwise he's a pretty healthy guy, no real risk factors or your traditional risk factors, not a hypertensive, never a smoker. He told us that his mom told him as a kid that he did have a rash, but otherwise, no other sort of medical problems. He doesn't take any meds or over-the-counter pills, herbal supplements. None of that. Vitals slightly tachycardic, cardiovascular exam, normal heart sounds, slightly tachycardic, no rub, that was auscultatable. On presentation, his inflammatory markers slightly elevated. His CRP was 15 and his ESR was 73, which is significant. Troponin was normal. I have his EKG up here. Hopefully everybody can see it big enough. But basically, what you can see is sort of these diffuse ST elevations or changes in some PR depressions, PR elevation, and AVR. So at this point, normally in front of everyone, I would have sort of posed this question out to someone, but what possibly could be a differential in this setting? It's sort of a giveaway from the title of my talk that it's probably pericarditis, but I just wanted to kind of go over some of the differentials at this point. One thing to note is when you're kind of going over LVH with repo versus pericarditis, there's some factors that can help. One, the clinical picture, sometimes the guys with repos are younger adults, but they're asymptomatic. They're just getting an EKG for whatever reason. They do have it's usually, it's rarely diffuse, but usually it's more localized, probably V4 through V6, lead 1. There's some people have proposed a ST segment elevation to the T wave height, that ratio. If it's more than 0.25, the ST to T is likely suggestive of pericarditis. If it's less, suggestive of repo. So pericarditis, essentially, which is the answer in this case, is not a very, it doesn't kill too many patients. The mortality in some series, less than 1% or in the realm of 1%. But it's a very morbid condition and, causes a lot of, significant discomfort and pain to the patients who experience it, and can be troublesome to treat as well. So what is it? Basically, it's inflammation of the pericardium. Now, there's a definition based off of time that was put forth in the ESC guidelines first. Interestingly, the ESC, most of the slides and the references are from ESC guidelines. That ACC or AHA haven't put forth guidelines yet. So basically, we classified into acute, which is basically this event or pericarditis lasting about 4 to 6 weeks, but less than 4 weeks classically. This term called incessant, which can basically be greater than 4 weeks or progressing beyond 6 weeks in certain instances, but less than 3 months. Recurrent, in the sense that a patient had pericarditis, it resolved within 4 weeks. He's had a symptom-free interval for 4 weeks, and then he has pain again after a 4 to 6 week break in between. And chronic, which is basically pericarditis lasting more than 3 months. Now, this sort of seems random or arbitrary, but it sort of is. But the helpful part about this, for me, was what I took out of this is based on the duration and the time, it can kind of give us a sense into what the etiology or causes could be. Because in most cases of chronic pericarditis lasting like less than 3 months without remission, it's probably not your run-of-the-mill like idiopathic or chances are it's not viral. It could be some autoimmune disorder or like some other underlying systemic disease, which could be kind of causing the pericarditis, which I'll get into. Now, from these patients who have acute pericarditis, a large majority of them recover. So about 20% can recur into that recurrent phase after some recovery in between. Now, in patients who have recovery, who have a recurrence, about 50% of them have been shown to have multiple recurrences, which just goes to show that it can be quite an annoying or morbid condition for those who are unlucky to have a recurrence. Moving into the etiology, the etiology could include infectious, post-cardiac injury in the setting of MI, back in the day when Dressler syndrome was more common. Autoimmune etiologies for it, probably related to systemic diseases in the setting of lupus. Could be neoplastic with malignant extension, either from a primary, which is rare, or Mets, which are more common. Mets in the lung, just infiltrating the pericardium as well. Metabolic, uremia, hypothyroid, drug-related, classically for the boards, isoniazid, hydralazine, nivolumab. Minoxidil, which can be used to treat high blood pressure sometimes, has also been notorious to cause these dangerous effusions. More commonly used for hair growth. Thankfully, I'm not there yet. Idiopathic. Now, I put this up last, is because despite all these reasons listed up there, idiopathic is by and large the most common, about 80%, depending on the series. In developing countries, with regards to infectious causes, TB is 1, 2, and 3 on the differential. In more developed countries, viral pericarditis or myopericarditis is thought to be the most common. Adenoviruses play a part in that. There was an interesting series from a few years ago where actually to make this diagnosis, because such a large lump of patients were deemed idiopathic, there was a group in Europe that actually did a pericardioscopic evaluation of these patients, where they actually biopsied the pericardium to get a sense of what might be the tissue or the disease process causing it. To their surprise, which sort of established this 80% rule, is that a lot of the time it was sort of classified as auto-inflammatory, which I'll talk about in the slides ahead. And viral etiologies were probably found in about 10, 15 to a max of 20% of the cases. So the evaluation of a guy who was suspecting pericarditis, this is where your good old H&P plays a huge part in this, actually, because the symptom of chest pain, which is pleuritic or this positional, worse from leaning back, improved bending forward. In physical exam, you can have a pericardial rub. On simple tests like an ECG, where you kind of have these diffuse ST elevations, as I showed, and PR depressions, it's elevated in AVR, which can help make these diagnoses. So it's just kind of spending time with the patient, actually kind of eliciting an H&P and getting a simple test in a lot of the cases can help you with the diagnosis. They are additional markers, like blood tests, inflammatory markers such as ESR, CRP, troponins that can also help in this diagnosis, an echo, which I'll get into. Now, with regards to I'm presenting the ideal patient. Like, he's like, oh yeah, when I take a deep breath, I have pain. Like, but we all know from taking HNPs that unfortunately none of them really follow the textbook. It's the same case for pericarditis. None of these symptoms or signs that I've listed are really very sensitive or specific. Yeah, you can hear a rub in up to 35% of the cases. An effusion or elevated inflammatory markers. In effusion, I mean pericardial, can be seen in up to like maybe 50-60% of the cases sometimes, but oftentimes an echo could be normal. The inflammatory markers are also reportedly normal. ESR, CRP are more likely to be elevated if it's truly inflammatory in that setting, but there are exceptions to this rule as well. Troponins can be elevated in up to 30% of the patients, but what I'm trying to get at is your only like reliable sort of like backdrop or fallback is really nothing. You kind of have to put everything in together. Chest pain, like which sort of has that pruritic component and positional component, can be your best friend in this situation, because a large part of them, that's kind of what you're basing the diagnosis on, practically speaking. Moving into the ECG specifically, like there's different like stages that have been like postulated, basically with stage 1, kind of like that ECG that I showed you, which has these diffuse kind of ST elevation at sort of beginning at the J point into the T wave, and PR depression, which can progress to gradually as you treat it, or it just progresses to its natural disease course. The J point kind of returns back to baseline, and after which you see some T wave inversions after T wave flattening. It's very interesting because now we all know that sort of dipole happens endo to epi, and then repole happens epi to endo, and pericardium is like right outside on the epi. So essentially, that's why a lot of the abnormalities that you see begin at the sort of like the repolarization phase, more of the QT, and then like as you get better and like the disease process improves and that inflammation improves, it kind of subsides in that sense. There were some interesting like studies on like dog models in the 90s where they actually kind of did body surface potential maps in these patients, and they actually saw that in these patients who had like not pericardium, like pericarditis specifically, but in patients who had like inflamed hearts or myocarditis for whatever reason, these inflamed potentials, or these surface potentials that they had kind of mapped out from the pericardium into the thorax. And interestingly, through these pericardial like recesses or folds where the pericardium actually lifts off the surface of the heart, kind of and connects with the thorax, like surrounding the aorta and the atrium, the pulmonary veins, is where a lot of these foci from the thorax entered into the heart, causing like ectopic rhythms. And like we all know with AFib, you have PVI or pulmonary vein isolation, which, and at this time, this hybrid ablation, endo and epi, have been shown to like help, which is, I just thought it was interesting. It's sort of unrelated, but it's just interesting that it dated back a while. Now, I kind of went over this briefly with regards to the elevated inflammatory markers, the ESR, CRP, and tropes, which can be elevated. The ESR, CRP should, like, the realm of elevation is much higher. It's almost always elevated, like, depending on the etiology and what it is, could be like north of 60%. And then coming back to the echo, which I put right at the end over there, I forgot to mention when I went over the ECG of our patient initially, she had a small effusion. I'll go over another echo picture first later. But so the echo, one thing to remember is that in a large majority, like almost half of these patients, it can be completely normal. Sometimes, like, not always, you can see there's a large effusion, which helps in making the diagnosis. Sometimes you can see signs of tamponade, which is very rare in the setting of acute pericarditis, in the realm of 1% or less. And strain has been postulated by some authors, with the, like, the plethora of literature on strain in recent years. It's also been shown, depending on when it's done, if there's myocardial involvement, specifically like myopericarditis, like decreased strain in that area can point towards that region being involved. Now, basically, I went over all of this in like a patient you're suspecting, but based off of the ESC guidelines, to make a diagnosis of acute pericarditis is how you clinch it. Basically, if you have the typical chest pain, the ECG changes, a pericardial rub, and a new pericardial effusion. What they say is that you need at least 2 of these 4 criteria to make a diagnosis. And a large majority of like the studies that I'll be going over kind of use these as the diagnostic criteria to say a patient had a recurrence or a patient had an initial episode of pericarditis. Moving on into the pathophysiology of pericarditis, which like, while this is like a busy slide, basically what I'm trying to convey is like just a couple of points here to kind of simplify this. Now we all know like the pericardium, like as a structure, is avascular, but at the same time, I'm saying that it gets inflamed. So like what I'm basically trying to make y'all understand is that essentially it is an inflammatory process. What we've learned in recent years is that whatever that initial insult is that causes injury to the pericardium, which could be like from any one of those etiologies that I described: infectious, idiopathic, viral, autoimmune. There's injury to the pericardium. With this injury to the pericardium, basically causes some release of inflammatory markers. And what we've learned in recent years is emergence of what we call the inflammasome. The inflammasome is basically central to the pathophys of this condition. It's basically a cytosolic macromolecule, which for me, like, because obviously I'm not a bench researcher, but in my head, to make me understand this, it basically has two parts, like a sensory part and like a protein part. The sensory part is important for like recognizing these what we call DAMPs and PAMPs, which are damage associated like molecular patterns and pathogen associated molecular patterns. Pathogens could be viral, damage associated could be autoinflammatory, uremia, even cholesterol. So basically what these receptors on the surface like could be like TLRs or toll-like receptors. For whatever reason, whatever that injury is, it causes these receptors to kind of get activated to kind of recognize these patterns which are causing the injury. When that happens, it just basically triggers an inflammatory cascade, which leads to neovascularization and release of these factors that can cause inflammation through a variety of mechanisms, which is like which I've kind of gone over there in the slide. This is basically going over the DAMPs, and the rest of the slide is just going over like where different medicines have been tried to like target to treat this condition, like act on different parts of this inflammatory cascade. Basically recognize some kind of an insult with the sensors, trigger like a release of multiple inflammatory substances. The best categorized or like the most well-studied inflammasome is this inflammasome called NLRP3, which have like a bunch of components like IL-1 beta, and multiple other like inflammatory like mediators or markers. So like final common pathway is inflammation, revascularization or neovascularization, which causes like, sort of a vicious cycle with progression and more release of these markers with continuing injury and free radical release. I hope that made some amount of sense. All right, so now we have this guy. We've made the diagnosis of pericarditis, right? So, I mean, what do we do about it? We've learned that a large proportion of these patients get better. What do we start for him? With prednisone? Should we take him to the cath lab? I mean, we've already moved past, so we know it's essentially pericarditis. The point of this slide is basically saying there should be a combination therapy with colchicine and indomethacin, and I'll get into that in a second. So NSAIDs. So classically for this condition, different ones have been studied, like aspirin in the inflammatory doses of like 700 to a gram Q8, ibuprofen, Motrin 600 to 800 Q8, and indomethacin 50 milligrams Q8. In an IV version, ketorolac has been tried, but it's advised not to use it for more than 5 to 7 days. It's generally used in the realm of like 1 to 2 weeks, which is supposed to cause improvements. And then you kind of taper over the course of like 1 to 2 weeks after that. And you also kind of watch for the patient's symptoms and CRP, like inflammatory markers, to see if they're actually responding to treatment. Yeah, so that's, and then you go off of this and symptoms. Now, in this, like it always comes up, like it's easy, it's on paper, but a lot of our patients have CKD. A lot of our patients, like, some patients could be post-MI. In these two scenarios, it's advisable to use aspirin in the inflammatory doses as listed above. Most of the times, like a large proportion of these studies, like when you use aspirin for like prolonged doses, you also use GI prophylaxis, letting of like Protonix or omeprazole or something in that realm, especially if it gets to the realm of 4 weeks or longer. I was looking back because, we all know that you don't use NSAIDs post-MI. Dating back to as early as the 80s, again, this was on like dog models where they induced ischemia in these in dogs, like, or infarctions. And they found that in dogs that received NSAIDs, the time it took to form a myocardial scar, like to complete the infarct, was that much longer, which would made patients more like, or I guess could make patients more susceptible to like arrhythmic complications. That's why in this setting, like aspirin would be preferred. Now, I spoke about colchicine. It's there's a large group out of Italy, like headed by Dr. Imazio, professor, I should say. He, like, since the 2000s, like a ton of research in this subject has just been done by his group. And like, kind of where we get most of our data is from there. Basically, the dose can do it at 0.6 BID for people more than 70 or 0.6 daily for less than 70 kilograms. Duration, the acute setting is 3 months. Now it's pretty, I wouldn't say it's well tolerated. Like a lot of the patients have diarrhea, unfortunately, but it leads to discontinuation in maybe about 8 to 10%, at least in the studies, of the drug. Also, myelosuppression can be a side effect. How it works is it inhibits microtubule formulation, thereby disrupts cell mitosis and transcription, that prevents the inflammatory cascade from perpetuating. Now, where do we get the data on like colchicine? Is basically like 3 key trials that I mentioned over there, which is CORE, COPE, and ICAP. And I'll get into them. But to kind of understand like what it does is just understand that colchicine, not by itself, all the studies used it in addition to like, an anti-inflammatory like an NSAID, reduces symptoms, reduces like duration of pain, reduces length of stays in the hospital, reduces recurrence of pericarditis, and reduce rehospitalizations. So, I mean, almost too good to be true, but this is what the data shows. And comes from the CORE study. The CORE study was basically in the early 2000s, again, by the group in Italy. They have 84 patients. CORE essentially means R stands for recurrence. Basically, these were patients who had pericarditis and were having a recurrence at the time. The proportion of patients on steroids in this study was in the realm of about 35%. So a lot of them were still on aspirin. And the study was, when they came back, you either just continue with whatever they were getting or add aspirin plus colchicine in the realm of 0.6 BID. Basically, they got a loading dose of 1, but sort of like extrapolates to 0.6 twice a day. And we found that in these patients treated with colchicine, the duration, 6 months in the setting of recurrence, was significantly lower. It's 20% in the colchicine group versus 50% in the aspirin alone group. And these, like, a lot of the studies have like kind of sell themselves on relative risk reduction. This is like a lot of the colchicine data is actually like absolute risk reduction as well. Similarly, COPE basically means in the acute setting, acute pericarditis, this colchicine was added for 3 months, and again showed a benefit of like a 10% versus 30%. 10% being like standard aspirin therapy alone, aspirin plus colchicine, and 30% being standard aspirin therapy alone. This was basically in the acute setting preventing a recurrence. ICAP was basically in patients who are ongoing acute pericarditis to prevent what they call incessant pericarditis. This was about 240 patients with a pretty large study for patients with pericarditis. And essentially, it improved pretty much everything: hospitalizations, recurrences, symptoms, and patients were symptom-free at 72 hours, those who were on colchicine plus aspirin from the get-go. I should note that there was one study, again in Europe in the late 2018s, that did not show a benefit of colchicine in patients with pericarditis, but some criticisms of that study was that the definitions they used for pericarditis were different. Like they didn't go off the 2 of the 4 criteria. They used 1, which was chest pain, which a lot of these patients might still have, which could be vague. And 2, it wasn't protocolized to start colchicine at the get-go. Depending on response to initial therapy, colchicine may have been added, which some people say was too late. Another important point of like in the acute setting is basically exercise restriction. For 3 months is what's advised. The thought process for this is basically neovascularization, reducing heart rate, reducing stretch with like reducing heart rate, and reducing basically blood flow and free radical mediated injury. So in the acute setting, you have 2 of those criteria. It's basically NSAID plus colchicine plus exercise restriction. As a second line, in case these NSAIDs are contraindicated for whatever reason, you can use low dose steroids. I say low dose because in the initial COPE study, patients who were on higher doses of steroids prior to the initiation of colchicine in addition had were independently associated with increased risk of recurrence. Since we've all become pros at social distancing, we're getting innovative with doing pretty much everything these days. So now this guy, he's been treated. What could happen to him? What are the complications? 15% of the time you could have myocardial involvement or myopericarditis. Tamponade is rare, as I was saying, it's less than 1% in the realm in the acute setting. Unfortunately, the most annoying part is recurrence, or the most morbid to the patients, happens in 20 to 30% of the time. After that first recurrence, it keeps happening over and over again. Constriction, which is rare, and again in the realm of 1%. What are the risk factors to have these recurrences or complications? Basically, that's one of my questions is basically, but the answer here is poor response to NSAIDs at 1 week is thought to be one of the risk factors for recurrence or complicated pericarditis. Rapid tapering of NSAIDs, less than 1 week. Rapid, if patients are on steroids and they were tapered rapidly to higher doses of steroids compared to lower doses of steroids, the persistently elevated inflammatory markers, such as CRP. And some authors also postulate that persistent late gadolinium enhancement on MRI has also been shown to be a risk factor for poor prognosis or recurrence. Back to our guy, he's treated, he's better. We thought all's well that ends well. And basically, kind of going over his course over 3 months after that initial presentation, he had been to the ER a few times, got admitted a couple of times, again with chest pain. Every time he kind of got his steroid, his NSAID dose increased, was on colchicine again. And on one of these admissions was when we saw him on the HERS service when he had come back. This was his echo at the time. Again, you can see a small amount of fluid, but what I'm trying to convey there is something that I'll talk about in a second. This was basically his tissue Dopplers, where you can see on the lateral annulus and EDE prime laterally is EDE prime medially is 7 and laterally is 9. But what I'm trying to convey from this, the velocity is 12 medially and lateral was 8. Something called annulosis or annulus paradoxus or annulus reversus can be seen in the setting of constriction. I'm not delving into constrictive pericarditis as a whole or too much because I think it's an independent topic on its own. There's a lot to talk about with regards to physiology and mechanisms of it, but I just wanted to touch upon this subject because in this setting, this patient back on this, what do you do? What do we do? So in this setting, the next step would be to start low to moderate dose prednisone. This is someone who's on NSAIDs and colchicine, but is having progressive symptoms. So you can basically see transient constriction in these patients in up to 10 to 20%. It's higher in settings of where you've had post-cardiac surgery, but the treatment and the pathophase for that is slightly different as well. So steroids and pericarditis. We all know steroids is that medicine that everyone loves to point fingers at. And are steroids really bad? In the setting of pericarditis, basically what it's been shown that higher doses of steroids have independently been shown to increase risk of recurrence and associated with a prolonged disease course. But regardless, when you're stuck and you have to start these patients on them, you get them started on low to moderate dose, which is 0.2 to 0.5 milligram per kilogram. And is a specific taper, which I'll get into as well. The problems with steroids are we all know that initially they help pretty much everything. And then after time, they start to cause adverse effects and cause complications for pretty much everything. So we get into the cycle where we're pretty much stuck. We're dependent on steroids. And, it's hard coming off of steroids. So in pericarditis specifically, steroids in the acute setting can be second line, when you can't use NSAID for whatever reason. The dose, again, 0.2 to 0.5. Duration is usually in the realm of more than weeks to months. It's important to know that if you have more than 20 prednisone milligram equivalents, more than 3 weeks or 4 weeks in some papers, You should have backroom prophylaxis, which is important to remember. I think I mentioned it, but for all these patients who are in the realm of like weeks of high dose NSAIDs, should be on GI prophylaxis as well. In steroids at a lower dose, which is like commonly was used as like 0.3 to 0.4 mg per kg compared to like almost 1 mg per kg. The lower dose has been shown to have lower risk of recurrences, lower hospitalizations, and lower side effects compared to the higher dose, which is like greater than 0.5 in the realm of 1 mg per kg. Now, tapering of steroids once you've achieved a target is basically, you start to see some response with regards to symptoms, inflammatory markers, and depending on what dose you are, if it's more than 50 or less than 50, you taper it between 5 to 10 milligrams every 2 weeks is an easy way to remember this table. So this guy, now we had seen him, like chart checking him and stalking him. He was initially started on 0.5 mg per kg of pred, which was tapered off. Like whenever we weaned down, I think to the realm of like 15 milligrams, if I'm not mistaken, or 12, he ended up having like some recurrence of chest pain. At this point, he was obviously on multiple medicines. Now, this brings me to my next topic. Like again, like, where we're stuck with this guy, we know what's going on, but unfortunately, like, it's a morbid condition, it's difficult to treat, and these guys have pain for whatever reason. Actually, not for whatever reason, for pericardial inflammation. But it brings me to the next topic. Like, I want to touch upon like advanced imaging and how this can help us in this setting and what it brings to the table. When I say advanced imaging, I basically mean cardiac CT and MR in addition to just a standard echo, which is always going to be like, mainstay for a lot of these cases. Now, what it helps tell us is if there's ongoing inflammation, and 2, if there's evidence of constriction. It can be physiology or calcification. Now, CMR can be used as an adjuvant to echo. What happens is, like, the presence of late gadolinium enhancement on these patients can and pericardial fluid or edema can touch upon like active inflammation. In the setting of constriction, you actually have sort of active, with the cine images, you kind of see ventricular interdependence. So it's a good way to like establish the presence of constriction as well. This again, if the diagnosis is not clear on echo. There was a recent study from a few years ago which showed that basically patients who had LGE, like, or some evidence of inflammation on an MR 4 weeks out after the initial episode, were more likely to have recurrences and relapses of pericarditis. And that's why some authors like put forth that the presence of LGE on an MRI should be used like as an adjuvant in the guidelines, the 2 out of the 4 criteria to include it there, but it's not there yet. It's just like a cool image of an MRI kind of going over the different layers, going from epicardial fat to the different layers of the pericardium, the visceral and the parietal with an effusion in between, and pericardial fat around it. You can see you can also see thickening and edema of the pericardium in these settings, which can also point to acute inflammation. Now, CT plays like also a helpful role, but in a different sense. Basically, the idea is like where diagnosis, again, of constriction is unclear predominantly. What a CT brings to the table is that it can kind of give you a sense of pericardial calcification. And sometimes because of the calcified pericardium, it can sort of inflame the adjacent myocardium, which can also cause which can also cause myopericarditis, as shown in these images, like the thickened, the calcific pericardium with inflammation of the myocardium. Also, from a diagnostic perspective, sometimes doing these scans, you can find like lung malignancies, which help, a radiation injury, which can also be a cause for like effusions and itis. So it helps in that setting as well. Remember, they're only as an adjuvant to echo, which is usually our go-to. This is just some more images kind of showing sort of like pericardial thickening, some fluid as well. So this is sort of just a summary slide of the images. Basically, in the acute setting, you can have a normal echo. You can have a regional wall motion in the setting of myopericarditis. You can have an effusion. CT and MR is not that commonly used in the acute setting, but can be. What they bring to the table are like pericardial fluid or inflammation. Thickened pericardium, late gadolinium enhancement kind of suggests acute inflammation. With the CT, you can see thickened pericardial layers. In the setting, as it progresses through like constriction, recurrence into constriction, you can start to see a septal bounce with an echo. the mitral and tricuspid inflows, ventricular interdependence, depending on whether it's an inspiration or an expiration, rated to like basically decrease intrathoracic pressures, right heart filling, inspiration, right heart predominates, expiration, left heart predominates, annulus reverses that I touched upon in the tissue Doppler over there. Basically, why this happens is, normally the lateral annulus moves more freely, but in the setting of pericarditis, it's more tethered. So that way it's not able to move it's not so much that the medial annulus moves more, it's just that the lateral annulus is tethered and can't move enough, which relatively increases the motion of the medial annulus. CT and MR, like as I was saying, can touch upon calcification. MR in these cine images is beautiful to kind of like, has really cool images to demonstrate constrictive physiology, and persistence of late GAD enhancement can point towards ongoing inflammation. That's basically just a summary. I just want to pause, kind of go over some trivia. I'm not sure if everyone recognizes this guy, but this is Shaun White, Olympic gold medalist, like with snowboard and winter sports. He as a kid had tetralogy of Fallot and pericarditis after his surgery. And, on the classic realm, you're sort of like advised to do exercise restriction, but in his case, he clearly defied the odds, and I think he's won about 14 Olympic golds or medals. So we can give advice in certain settings, but at the end of the day, depending on how you feel, like patients are going to do what they're going to do. That's what I'm trying to say. So now at this point, this guy is now 38. He's just gotten a year older, and medically he's gotten much older. He kept this part of it's kind of like more to strike home a teaching point. Our patient actually got better. We were able to be weaned off of steroids, but to be helpful for the sake of like going over more therapies, what should we do, like, in these settings, in a patient who, whenever we try to wean steroids, continues to have pain? I mean, basically just give up, be like, that's it. Or, keep trying to come up with something new. What we can do is a couple of things. We can always call someone who has more experience, knows more. There's newer anti-inflammatory therapies that have also been shown in recent years to be helpful, and I'll get into them in the next part of the talk. Some of them are Anakinra, which is an ion wall antagonist, azathioprine, infliximab, IVIG. Basically, what is Anakinra? It's an IL-1 antagonist. It's a sub-Q medicine, usually given daily though. And they studied it in this one, I would say, like large trial, because it's reasonably big for pericarditis. It's at 20 patients. It's called the AIRTRIP trial. What they did was, in these patients, the population that they included was people who had multiple recurrences, elevated CRP, which was an inflammatory pericarditis. I say this because there is an entity called burnt out pericardium, or like purely like calcific constriction, where inflammatory markers are not elevated, which I won't be jumping into. And a lot of these patients, up to 50% of the patients in the study, were steroid dependent, where they couldn't be weaned off. What basically these guys had were they were either randomized to getting Anakinra or like continuing standard of care. What it showed was that it dramatically reduced the risk of recurrence. In the Anakinra group, the recurrence was in the realm of about 17 to 18%, whereas the risk of recurrence in the guys who got placebo, who were on the standard of care though at that point, be it steroids or whatever they were on, was almost in the realm of 90%, which is like an absolute risk reduction of north of 70, which is pretty crazy. But unfortunately, as with any medicine, it's, it was showed that it can cause LFT abnormalities. It's a sub-Q medicine that's given every day. You kind of have to use it in the realm of months. So we all know how much our patients hate like DVT prophylaxis with Lovenox, with the injections, insulin. So compliance can be an issue. Obviously in trials, it's going to be better. And LFT abnormalities, the realm of hundreds, not so much in the thousands, or causing like fulminant hepatic failure we're seeing, but it's just something to keep an eye on. Some of the other therapies could be IVIG. It's usually given in the inpatient setting. It's like a 5-day course is what can be what has been shown in some like scant data. Azathioprine in the setting of like lupus sometimes it's been used. It's not expensive, but it comes with its own host of like side effects. It has both of these agents, improve symptom-free survival, symptom-free rates, and try to help wean patients off of steroids. Interestingly, coming towards the end, very recently, like in the last couple of months, actually, this was from January, there's this phase 3 trial of this agent called rilonacept, which came out in the New England Journal by a group predominantly by Dr. Klein, who's in the Cleveland Clinic, and Dr. Emesio, who's out of Italy. Much as I have said already, like a lot of the data and the papers surrounding pericarditis come from their groups. And in these patients, basically, he had 80 patients in the study who were given a 12-week run-in with this therapy called rilonacept. It's a weekly sub-Q injection. And basically, after that 12 weeks, depending on their CRP, if it responded, they were included either to continuing rilonacept or getting placebo at that point, and basically assessing for relapse or recurrence. 7% of the patients in the rilonacept group, compared to 70% of the patients who were on placebo, had a recurrence, which just goes to show that, again, it works phenomenally well. Predominantly by the same inflammasome mechanism when it blocks IL-1. Now, but it's still not yet in the post-marketing phase, and probably more data is going to be coming out. Anakinra, there's an ongoing trial which I believe concluded patients that they were enrolling for in the mid part of last year. That was Anakinra in the setting of acute pericarditis. So more data is going to come out in the months ahead. One big thing that I didn't talk about, which I'm touching upon now because we're all medicine, is when do we consider surgery? Now, initially, my understanding this was wrong. I have to admit, I thought pericardiectomy was something which shouldn't be as complicated, kind of like just removing a wrapper or a cover, but it's a lot more complicated than that. And is reserved as a fourth line or a last resort in patients who have a very poor quality of life, kind of this refractory nagging chest pain, and who are not kind of able to carry on their daily activities of living from this refractory pain, despite all of the medicines mentioned above. Now, despite this, I saw this one series out of Japan, which showed that it's not by any means a benign procedure. These patients, it carries a risk of about a 10% mortality and a prolonged hospital course. AFib was common to develop after. Now, so it's advised that ectomies be performed in these patients, with refractory recurrences and pain, poor quality of life, or in the setting of calcific constriction, which is it's the recommended treatment. But again, not touching upon that. Ideally, it should be performed at a higher volume center. And the mortality, 10%, was it was higher in patients who were getting a reduced sternotomy, or in patients with higher comorbidities, which is sort of expected. Kind of going over the same summary is in patients with recurrent pericarditis who are free, you try the same thing again. If it doesn't work, add steroids. You can add Anakinra, IVIG, azathioprine, rilonacept in the days and weeks ahead. And lastly, as a last resort, refer to pericardiectomy. It's not as easy as we'd like to think it is. Same thing, kind of wrapping up the case over here. For sake of discussion, our patient was started on immunologic therapy with Anakinra and tapered off steroids, did well. Moving on to the references. Like I said, a large portion of the patients on the studies were from this one group in Italy and a group in Cleveland Clinic, and the ESC guidelines in 2015. Want to thank Dr. Mitchell and Arnav, who I guess he found out I was talking about this yesterday after Ms. King sent out her email. He was kind enough to send me some of his studies, which he's done on the subject, which I read over. At this point, I'd like to stop, ask anyone if they have what questions I can answer, and anything else. Thank you.
Thank you, Ram. Good talk. Good review. I guess it's just sort of a bit, obviously the topic still at the top of everyone's mind, but COVID-associated pericarditis, not seems to be not terribly common, but certainly there are some cases out there. Did you come across anything related to that, or any?
Most of what I read in the setting of COVID was more myopericarditis, more related to the setting of like myocarditis, which is more established. I don't believe I saw any cases of isolated pericarditis from COVID or how they were treated. I could be wrong, but I didn't come across that.
No, I think that's been our experience, that it's it's generally mild and sort of a minor player in the background in some maybe more severe disease where either the myocardium is involved or extensive sort of pulmonary involvement. So it's typically not. I believe I've seen some very rare case reports of just isolated pericarditis from COVID, but my suspicion is wouldn't necessarily change the treatment algorithm that you proposed or sort of standard therapy for idiopathic or viral pericarditis.
Ram, I had one case, the standard rep, I had one case in April last year with an older lady with who was initially COVID negative, came with a large unexplained pericardial effusion, almost pre-tamponade, and we drained it, it was bloody. And in the course of her hospitalization, it turned out to be COVID positive.
Wow.
So we had one case like that. I think it was Rebecca's patient, but we had one case early on when COVID came around last year.
Got it. Thanks, Dr. Ram.
Hey, Ram. So this is Arnav. Just one thing I wanted to touch base on. The really good talk, of course. So there is actually a post-trial registry that is going on right now for the rilonacept trial. And so all of you, if there is any patient that you think is a candidate, someone who has a lot of gadolinium enhancement, recurrent pericarditis, please feel free to touch base so we can probably enroll them in this post-trial registry. The other comment that I had was that it's very important to differentiate these patients. So if you have a patient who's coming in with, say, 1 or 2 episodes and presenting with constriction, and they have enhancement on the MRI or their CRP is high, and these patients, they actually demonstrate something called a transient constriction, where basically you treat them with anti-inflammatory therapy, and they actually get better. Now, if this same patient comes with a lot of calcium, like you mentioned, you did a CT, there is a lot of calcium, there actually could be good candidates for stripping, especially if they have come with a lot of episodes and now have a burnt out pericardium. And if there is a patient who is coming with recurrent pericarditis and probably like their 6th episode, 7th episode, and they have enhancement, we have data which shows that these patients need to be treated with anti-inflammatory therapy for a longer time. Because as we were discussing, the mechanism for enhancement in cardiac MRI for pericarditis is actually quite different from the myocardium. In myocardium, the gadolinium enhancement is from scar, but the pericardium is avascular. So in these patients with repeat recurrence, there is neovascularization, and that is the mechanism behind why they light up when you give gadolinium. Just a couple of points.
Thanks, Arnav.
Okay, nothing in the chat box, so no other questions.
Hello, Robbie.
Oh, yep.
So the question always comes up about what's annulus reversus and annulus paradoxus. Yeah, they're not the same thing. I kind of messed up one time and thought they might be the same thing, but they're not. And this reversus has to do with and Mon is listening to me and he knows about this too, is the fact that the usual lateral annular tissue Doppler annular velocity is higher than the septum. And when that gets opposite, that makes you think that the lateral wall is tied down by a constricting pericardium, and that has to do with constrictive pericarditis. The annulus paradoxus is the calculation you make when you think that the filling pressures are going to be low according to the higher tissue Doppler numbers, and they calculate to be normal, whereas you know they're higher. So
Gotcha. Okay.
that's kind of my definitions of that. And I just say that because those of you who are interested in constrictive pericarditis and all, might want to look at that and get those definitions in your mind.
All right. Well, thanks again, Ram. Good talk, good review. And thank you everyone for tuning in this morning, and we'll see everybody next week.
The preceding program is copyrighted by Emory University.